It's my pleasure to introduce Dr. Patrick Coleman. He's the Director of Cardiology for Northern California Medical Associates, and he's been part of our group now for 22 years. Pat received his doctorate of medicine at Northwestern and stayed on there for internship and residency, and he thought he wanted to be a researcher and spent a couple of years in cardiovascular research before he went on to Tufts New England Medical Center for clinical cardiology and then interventional cardiology. Pat's been instrumental in building the interventional cardiology program here over the last decade and instrumental in several other aspects of cardiology care, including his strong work in getting AEDs placed in schools and other institutions around our county region. He's going to talk today about transaortic valve replacement, and he's also going to touch upon some of the questions about the new guidelines for hypertension and dyslipidemia. Welcome, Pat Coleman.
Thank you. Can everybody hear me okay? Good, thank you. Well, let me add my thanks to you for taking the time out of your busy schedule to come and join us for our annual symposium. As Tom mentioned, I've been tasked with a couple of different areas to talk about. One is a new technology for treating an old valve disease, aortic stenosis, a technology that we think is about ready for prime time here, and you'll be seeing it in more and more of our patients. And then at the end, switch horses and talk a little bit about some of the new guidelines for treatment of blood pressure and lipids, and try to shed some light and distill some of the newer recommendations and see if we can make some sense out of them. These are my disclosures. I'm going to talk about products or ideas from both companies, but there's data behind them. I don't think it should be much of an issue. Aortic stenosis is a very common valvular problem that we see all the time in our practices. On the left-hand side of the screen is a minimally diseased trileaflet aortic valve, and on the right side of the screen is a heavily diseased aortic valve with a lot of calcific concretions which prevent or impair valve movement and obstruct ejection of blood from the left ventricle. There's another number of different etiologies for aortic stenosis. In young patients, it's usually congenital, usually a unicuspid or a bicuspid valve. Bicuspid valve disease can be seen well into the 50s and 60s. Rheumatic disease can sometimes cause aortic valve disease, though it's usually aortic insufficiency. But by far and away, the most common cause for aortic valve disease that we see in all of our practices is age-related degenerative calcific aortic valve disease, where there is inflammation and then deposition of calcium deposits, usually starting at the aortoannular junction and then spreading out onto the valve leaflets themselves, making the valve leaflets very immobile, causing that obstruction to left ventricular ejection. It's a fairly common problem. 2% of patients over the age of 65 have aortic stenosis, but 30% have echo-derived aortic sclerosis, which is the precursor or congener of aortic stenosis. And as we get older, that prevalence climbs to about 12.5% in the over 65 population. We're an aging group. We're an aging nation. The over 65-year-old population is growing in this country, and in Sonoma County, it's growing faster than other parts of the country. And when you break that down, the over 85-year-old population is growing the fastest. So we have a rapidly growing patient population that's going to have this disease. The majority of both the elderly and the non-elderly patients are candidates for surgical aortic valve replacement, but as you'll see, not all of them are. The symptoms are very common to us all: exertional dyspnea, angina, either due to the increased myocardial oxygen consumption from the left ventricular hypertrophy that develops, or because of actual compression of subendocardial vessels because of the increased pressure gradient in the left ventricular cavity. Syncope, which is usually exertional or post-exertional, sometimes frank heart failure, dizziness or palpitations. This slide's probably familiar to all of us in this room. This is from Braunwald's work in the early 60s, looking at this long latent period of asymptomatic disease, and then once patients develop symptoms, their mortality really climbs and their survival plummets. And you can see that if they present with heart failure, their chance of surviving 2 years is about 50%. So worse than a lot of cancers. And this is an example of what happens if we intervene in the valvular disease. This is from the surgical literature in the late 70s and early 80s, demonstrating in patients with symptomatic aortic stenosis, if you fix their valve, their survival improves dramatically here in the tan versus the blue if you don't fix their valve. So at 2 years, if you got your valve fixed, you had about a 90% survival rate. It's even higher now. If you didn't get your valve fixed, your chances of being alive at 2 years was about 20%. This is one of the most dramatic examples of an improvement in survival and an intervention that we can do in medicine. And whether you're asymptomatic in the dotted lines or symptomatic in the solid lines, if you get your valve fixed in the tan, your chances of survival over time is much, much improved compared to if you don't get your valve fixed, which is in the blue. And this is an interesting slide looking at patients who have severe aortic stenosis and what percentage of them actually end up getting valve intervention. And what it turns out is that only about 40 to 50% of patients who have severe aortic stenosis actually get valve intervention. So there appears to be either an unmet need or at least that many of these patients are not being referred for valve intervention. And it's unclear why that is. It may be because there is a perception that because this is a disease of the elderly, that they're too old for valve surgery. But it turns out that if you are a healthy, and I stress the word healthy, 80-year-old, you have a chance of living at least 9 more years. And if you have a life expectancy of at least 5 years, your chance of deriving significant benefit from aortic valve replacement is significant. And for those patients who survive 6 months after their operation, their life expectancy matches that of aged controls. So maybe a misconception about age. One of the things that is important in terms or helpful in terms of thinking about whether a patient is a candidate for surgery is their risk of the operation. And the Society of Thoracic Surgery, the STS, has a risk score, a risk calculator that you can get online. Anybody can get it, it's free. You can Google it. And by plugging in various parameters of the patient's condition, you can figure out what their risk is. And this is just a typical patient we might see, 74-year-old male, class 4 heart failure, severe aortic stenosis by transthoracic echo, a portly gentleman, should probably see Robert, at 102 kilos, creatinine of 1.9, so moderate renal insufficiency, hypertension, COPD on home oxygen, mitral annular calcification causing mild mitral stenosis and mild mitral regurgitation, moderate pulmonary hypertension, and mild anemia. All of those things are pretty common in the patients that we see, and yet his risk of mortality with an isolated aortic valve replacement is almost 10%, and long-term morbidity or mortality is 41%. This person would have an STS score of about 10 to 12. And so this is a way of assessing the patient's risk for surgery. There are some other conditions which have a real impact on the patient's suitability for surgery that aren't accounted for in those scoring systems. Probably the most important of which is frailty. We are an aging population, and frailty really is a real thing. There is documented science behind it. It's a pro-inflammatory state. There's loss of skeletal muscle mass. And if somebody is frail, they really will have a very difficult time surviving a surgical operation. Porcelain aorta is where the aorta is encased in calcium, so when they actually open up the aorta to do the valve replacement, there's an increased risk of stroke. Chest wall deformities, hepatic issues, active oncologic or hematologic issues. It doesn't take into account if a patient's on dialysis, which increases the risks of just about everything. And patients the elderly have impaired cognitive reserve, dementia, and that really impacts their ability to survive an operation. So we have a large and growing population of patients who are going to develop severe aortic stenosis. And it's clear that all would benefit from intervention in terms of improving survival, but at what risk? And in the high-risk patients, are there options? And what about in patients who are felt to be inoperable? And that's where this new technology comes in. And it's called TAVR, and that stands for transcatheter aortic valve replacement. And it offers us an alternative to surgical AVR in those patients who are high risk and have severe calcific aortic stenosis. TAVR is a technologic advancement. It borrows from technology, old technology. When I was training in the 80s, we used to take balloons and put them across the aortic valves and blow the balloons up and hopefully opened up the aortic valves. That didn't work so well, but TAVR involves balloon aortic valvuloplasty. It uses that technology. It borrows from our stent technology, using metal stent frameworks to support the valve, but those stents can be crimped down on a balloon or can be collapsed down because of their mechanical properties. And it involves valve technology from the cardiovascular surgical side, where we use bovine or porcine pericardial tissue for valve leaflets. And this is just a picture of one example of a transfemoral approach where we're coming up from the femoral arteries. You can see the catheter goes around the aortic arch, and here in the aortic position is this stent framework, this metal stent framework, with a balloon blowing up the valve and keeping it in position there in the aortic position. These can also be put in through a small incision in the chest wall transapically, or through a small mini sternotomy about 4 centimeters long. You saw that in Dr. Wu's lecture, through the aorta approach here in the same direction as coming up transfemorally. And this is just a picture of the 2 commercially available valves that have been FDA approved. A and B here are the Edwards Sapien device. They're just 2 different generations. B here in the middle is the current valve. This is a cobalt chromium stent frame with bovine pericardial tissue as the valve. That's crimped down on a balloon. The balloon is expanded, opens up the stent framework, and pins the valve framework in the aortic position. On the right here is Medtronic's core valve. That uses a different technology. That's porcine pericardial tissue for the valve leaflets. It uses a nickel titanium alloy stent framework. That's nitinol. That's a self-expanding type of material. At cold temperatures, the framework is very malleable. It's collapsed down on a catheter and a sleeve is put over it. When the catheter is inserted into the artery and it comes up to body temperature, the stent framework wants to expand out to its original position. And this is just an X-ray picture of what this looks like. This is the balloon expandable type, the Edwards. Here's the big catheter coming up the aorta. This thing here is the transesophageal echo probe. So this is all done under continuous transesophageal echo monitoring. You can see here the valve is being positioned in the aortic position. There's little dots here on either side, so we know exactly where things are. You might see these little dark spots off to the side here. That's the calcium in the aortic valve itself. This is an example of the Medtronic core valve. You can see here, this is the transesophageal echo probe again. The catheter is being pushed across the valve itself. This band is that sleeve I talked about. It's being withdrawn here, and you can see the stent here starting to deploy, the stent framework. That band is pulled back, and the stent framework is starting to expand against the root, and then here it's completely expanded, and the valve is working. Well, what's the data behind this? This type of technology and this idea has been going on for the last 10 years. But it's really been only in the last 2 to 3 years that we've gotten some very good data that tells us that this technology is starting to be ready for prime time. And this is just one example from the New England Journal, published in 2011, looking at patients for transcatheter valve replacement. And this was the partner trial. This is a very busy slide, and there's only 2 important points on this whole slide that I'd like you to remember. Number 1, they all had aortic valve disease. And number 2, they broke them down into 2 cohorts, 2 groups. Group A over here, or partner A, was a high-risk group of patients. They were high risk for surgery, and they randomized them to either surgical AVR or transcatheter AVR. The other group, Group B, were patients who were inoperable. And those patients were randomized to balloon aortic valvuloplasty and best medical therapy. So it was either transcatheter valve or medications because they couldn't have surgery. Well, let's look at that Group B, that inoperable group. This was a very sick group of patients. They had a 50% or greater risk of surgery, or of dying during surgery. So they were truly inoperable. And what they found in this group was 3 things. Number 1, medical therapy wasn't very good. It sucked. There was a 51% mortality rate at 1 year with patients who got balloon aortic valvuloplasty and medical therapy, and at 2 years it was 70%. So medical therapy really wasn't a good option. Secondly, transcatheter valve replacement with a balloon expandable valve dramatically reduced mortality. It improved survival from 51% to 31% at 1 year and 68% to about 43% at 2 years. So there was a significant improvement in mortality. And thirdly, this was still a very sick group of people because at 1 year, 30% had died even though they got the valve, and at 2 years, 45% had died. This just underlines the significance of the comorbidities and how critically ill these patients really were. And this reminds me of how we started doing endovascular AAA repair. If you think back about 15 years ago when endovascular AAA repair started becoming a real going event, we only did it in patients who had a very limited lifespan because we didn't know if it was going to work or not. And so we started doing it in patients who had underlying malignancies and had inoperable cancers because their life expectancy was very short, but it really didn't matter. And that's how we learned that that type of technology was actually quite viable and now forms the basis for our endovascular aneurysm repair. And this slide just looks at the improvement in heart failure. On the far left is looking at the patients in the two groups. Most of them had class 3 and class 4 heart failure in the blue. But what you can see is over time, the patients who got valve therapy, transcatheter valve therapy, improved their heart failure class to mainly class 1 and 2, where the patients who got medical therapy did not. So these two slides show that in an inoperable group of patients, transcatheter valve replacement not only improves survival, reduces mortality, but also improves symptoms of heart failure. What about group A? That was the high-risk group. That was the group where they actually randomized them and compared them to surgery. They still were a high-risk group. They had a 15% or greater chance of mortality or irreversible morbidity and had an STS score of initially 10. They dropped that to 8, but that still captured a very high-risk group of patients. The transcatheter valve patients were actually further stratified into transfemoral or transapical approaches, but I'm not going to talk about that. But suffice to say, this was a randomized trial with surgery. And what you can see is that 1 year, the surgical and the transcatheter valve replacement mortality was quite similar. And at 2 years, it was almost exactly the same. And again, when you look at how the patients symptomatically did, they had initially mainly class 3 and class 4 symptoms of heart failure. That's in the blue here. But with either surgical or transcatheter valve replacement, they significantly improved into mainly class 1 and class 2. So these two slides show that in a comparison to surgery, in a high-risk group, transcatheter valve replacement behaves quite similarly and is not inferior to surgery in terms of mortality and is quite similar in terms of improving symptoms of heart failure. The Medtronic core valve has quite similar data, and they did two different studies. Their extreme risk study was the group of patients who were inoperable. The high-risk group was a head-to-head comparison with surgery. That was actually just reported last weekend at the American College of Cardiology. In the extreme risk group, that's the inoperable group, they actually used Edwards data of 51% as the baseline for medical therapy, and they too found a significant improvement in survival with their valve in terms of compared to best medical therapy. And this is the data in their high-risk group. This was published or presented. It hasn't been published yet. It was presented last weekend. This is a head-to-head comparison. And the reason this has gotten a lot of buzz in the last week, and you may have seen it, is their study actually showed a statistical superiority of transcatheter valve replacement compared to surgery in terms of all-cause mortality at 1 year. Now, I'm not saying that I think that transcatheter valve is superior to surgery, but that's what this one study did show. I think it does point out that this technology really is ready for prime time. It's something that we should be thinking about. And this last slide here just shows that the results are quite durable. This is again from the Partner A trial, the head-to-head comparison with the balloon expandable prosthesis, and just shows whether you look at death, stroke, or death or stroke from any cause at 3 years, surgery and transcatheter valve replacement is quite similar. So that's some of the best data that really shows that this technology is something we should be considering in our patients. But that doesn't mean there are not hurdles that we still need to overcome or think about and areas that we need to do more research in. And those include periprocedural stroke, the development of aortic insufficiency, bleeding or vascular complications, the need for a permanent pacemaker, the costs of the procedure, and exactly which patient population might this be most appropriate for. By far and away, stroke is the most devastating complication and something that we really are concerned about with this technology. The majority of the strokes, probably 50 to 70% of them, occur in the first 48 hours, so they're periprocedural, and they're usually related to the balloon aortic valvuloplasty or the manipulation of those large catheters in the aorta. The catheters are 18 to 22 French in size. That's about the size of your index finger. There can be late cerebrovascular events due to thrombus forming on the stent frames and then embolizing off, but that's uncommon. That's similar to what we see with stents, and that's why many of these patients will come back on Plavix or a platelet inhibitor for the first 1 to 3 months. When you look at all the data, the 30-day stroke rate appears to be about 2 to 6%. It does seem to be decreasing, but in the Partner A trial, it was as high as 7.5%. Surgical aortic valve replacement stroke rates are much less. The STS would say in a high-risk patient it might be as high as 1.5%, but in the Partner A trial it was 4%. I'll show you that data in a second. Contrast that when Keith does surgical AVR in all of his patients. You take all of his patients, both high risk, medium risk, and low risk, or high risk patients. His stroke rate is about 0.7%. So there's a big difference in the rate of stroke. So that's why this is gaining a lot of attention, a lot of research. There are many companies and people who are looking into cerebral protection devices analogous to what we use when we do carotid stenting to see if there are ways that we can protect the cerebral circulation during this procedure. And this is just the data from the Partner A trial. This is the head-to-head trial in high-risk patients. Statistically, no difference, but numerically, a difference in favor of surgery both at 12 months and at 24 months in terms of stroke. And you can see that the curves diverge very early on, indicating that the majority of these strokes occurred at the time of the procedure. Well, we do this procedure to treat aortic stenosis, but in the process we can cause aortic insufficiency. And the reason for that is because the aortic annulus is actually a D-shaped orifice. It's not round. Yet the current valve frames are round, and they do not oppose or seal uniformly all around the orifice, and you get perivalvular leak. That's what you see here. Here is the round valve orifice, or the valve structure, and then off to the side here in orange is the Doppler signal of perivalvular aortic insufficiency. And I'll show you a slide here, or a movie here in a second of some new technology which may address that. The problem is that perivalvular aortic insufficiency is associated with increased poor outcomes or increased mortality. There's just a paper published in Circulation this month that I was not able to get a hold of talking about that. That's the most recent data. This is from a group in Germany looking at an almost threefold increase in in-hospital mortality, very hard endpoint, if they were left with moderate or severe aortic insufficiency. So we make every attempt to minimize the amount of perivalvular AI after the procedure, and that, even if that means going back in and re-ballooning the prosthesis. Vascular complications are higher with transcatheter aortic valve. That sort of makes sense. These are large catheters. They're going in through the iliacs. You need at least a 7-millimeter iliac vessel to accommodate these catheters. They're done through vascular cut-downs. And so it's not surprising there's more more vascular complications with TAVR. There are more bleeding complications with the surgical approach. It's not that surgery has high bleeding complications, it's just when compared to TAVR, it's just higher. And that's because the larger incision chest tubes, and that those patients do go on cardiopulmonary bypass, so they're activating the clotting factor or clotting system and consuming factors and platelets. There is a difference in the need for permanent pacemakers after the procedure. You can see here the anatomic relationship of the aortic valve. Here is the AV node, the His bundle, and then the left bundle down here. So they're in very close proximation. And you can imagine that any pressure placed on the aortic annulus here could have the opportunity to damage the conduction system. And indeed, we see that with the Edwards valve, there seems to be, and that's the balloon expandable valve, there seems to be about a 3 to 8% risk of needing a permanent pacemaker after the procedure. With the Medtronic core valve, that seems to be higher, anywhere from 15 to 40%. The number seems to be settling down around 20 to 25%. And again, that probably both have to do with pressure or damage caused by the expansion of the valve frame. Contrast that with surgery, where there's a less than 3% chance of need for a permanent pacemaker after the procedure. Cost-wise, there appears to be a similarity of transfemoral transcatheter valve replacement and surgical valve replacement in terms of cost effectiveness, as well as dollar per quality of adjusted life year gained. With the transapical approach, that does not appear to be the case. The transapical approach appears to be more expensive, with minimal reduction in hospital stay and hospital costs, and not quite the same gain in terms of quality adjusted life years. The TAVR cost will decrease when the cost of the valve itself drops, and that's going to be a function of more players in the marketplace. There are currently about 9 different companies with valves in the works trying to gain FDA approval, and when there are more valves and ideas available, then the cost will drop. Currently, the TAVR valve costs about $30,000 compared to about $5,000 for the surgical valve. So there's a huge difference, a 6-fold difference. And this is just a little movie here. I think it's going to start. There we go. Of a company here in Santa Rosa. This valve is available in Europe. It is not available here in the United States. It is undergoing trials. It's instead of a metal framework, this is a synthetic framework that's filled with saline initially, and then eventually a biocompatible epoxy glue. The valve leaflets are bovine pericardium. This is inserted through the transfemoral approach, brought up and over the arch, and you'll see it go through along a wire through the aortic valve after valvuloplasty. The valve's unsheathed, and it opens up. Here it's filled with saline. Now the valve's starting to work right now. Even the ventricle is contracting around it. And then the top, or the aortic ring up here, is deflated. That's brought up. You can see it being deflated and pulled through the aortic valve by these 3 tensioning or adjusting rods, and they're labeled 1, 2, and 3, you see, and then the top ring is reinflated, and the valve prosthesis is adjusted where you want it. You can do an aortogram there in the blue and make sure it's where you'd like it. You want to see all the coronary ostia. You don't want to cover over the coronary. There's the left coronary ostia right there. And if you're happy with it, you can fill it with the epoxy through these tubes, and those tubes can be unscrewed and removed. If you don't like the position, you got things here, and then you do the aortogram, and you see the aortic insufficiency here. It's still filled with saline. You can readjust it. You can take the saline out, move it around. And this type of technology, where there's no metal in the framework, allows for more complete sealing around that D-shaped orifice. So there's much, much, much less aortic insufficiency. The other nice thing about this valve is if you want to take it out, it is reconstrainable. So this whole approach to transaortic valve replacement takes an entire team. If you think this is going to put Keith Corver out of business, it's not. Right now, this is just for high-risk patients, and actually Keith is one of the biggest believers and is an integral part of the team. He and I have been working on this probably for about 6 months to a year. It requires a multidisciplinary approach. The cardiologists evaluate the patients for appropriateness, the severity of the aortic valve disease. 2 cardiovascular surgeons also evaluate the patients for appropriateness in terms of needing surgery, and also certify that the patient's high risk. And then the interventional cardiologists and the radiologists go over CT angiograms of the vasculature to look for vascular access sites and complications. This is a team sport. It requires a lot of people. It's done usually either in a cath lab that is large enough and has been set up with special ventilation to make it acceptable as an operating room, because the patient may need emergency open heart surgery to replace the valve if something goes wrong. In the new Sutter Hospital, we're going to have a hybrid operating room, which is a large operating room that has been outfitted with the same kind of imaging equipment as in cath labs. 2 interventional cardiologists, 2 cardiovascular surgeons, as well as a cardiovascular anesthesiologist who can provide you with constant transesophageal echo monitoring, as well as technologists from the cath lab, and the OR scrub team. And then in the background is the pump team in case the patient needs to go on emergency cardiovascular bypass. So there's a lot of people involved in doing something like this. It's currently only approved for high-risk patients or inoperable patients, and that's who we're sort of keying this into. Will it ever become acceptable in moderate-risk patients? There are trials going on right now in patients with STS scores of 4 to 8, so a moderate-risk type of patients. But really, at this point in time, the stroke risk is really too high to say it's something that's an option for moderate-risk patients. Why would you accept an almost 10-fold increase in the risk of stroke? Now, as I mentioned, that there's a lot of energy being put towards looking at ways to provide cerebral protection, and I think once we figure that out, the technology will move forward. It's not applicable for other types of aortic valve disease, such as aortic insufficiency, and it's not been approved for the use in bicuspid aortic valves, though there are lots of single-center studies demonstrating that it can be used for that. The reason that it can't be used in aortic insufficiency is the technology needs that roughened valvular surface of that calcified valve to act as a friction point for the valve prosthesis to sit. With aortic insufficiency, there's usually not that calcification. I do think that technology will triumph in this regard, in that there will be other anchoring methods or mechanisms that will allow us to use this type of technology in aortic insufficiency. And it may be that technology similar to what you saw with the direct flow medical device will be the way to go. So the patient that we're currently looking at this technology for is somebody with critical aortic stenosis who is less than optimal surgical valve replacement candidate because of their comorbidities. They have an STS risk score of at least 8, and they have limited peripheral vascular disease, so they can undergo a transfemoral approach or have enough pulmonary reserve to undergo a transapical or transaortic approach. We're in the process of applying with CMS to be able to do TAVR here in Santa Rosa. It's a difficult task dealing with CMS, and I don't know how we're going to do. We also work quite closely with our cardiovascular colleagues at both Stanford and UC Davis to provide these options for our patients. So you'll see patients going there, and many times we'll go down with the patient and actually scrub in on the procedure. So I'd like to stop there for a second and then sort of switch gears here and talk a little bit about the new guidelines for hypertension and hypercholesterolemia. Last year, in mid-portion of 2013, JNC8 was published. Joint National Committee came out with some new guidelines, and they've caused a little bit of a shift or movement in how we treat hypertension, and we just thought we should mention that. When JNC8 was formed, they had 3 questions that they were sort of trying to answer when they formulated their recommendations. The first, were there any specific blood pressure thresholds that we should be identifying? The second was, are there any specific blood pressure goals, treatment goals, that we should be specifying? And thirdly, are there various antihypertensive agents that seem to work better or worse in various patient population subsets? So those are the 3 questions that were in the back of their mind when they formulated their recommendations. They came up with a different grading system. Remember, and for those of you who've been here in the past and have seen some of the presentations, we've had grading systems where there's a class 1, class 2, class 3, and then there was A, B, and C based on the strength of the data. Well, they got rid of that because that was confusing to everybody. And they just went back to sort of grade school, and you got an A, B, C, or D. A was a strong recommendation, B was a moderate recommendation, C was a weak recommendation, and D was don't do that. There was grade E, which is we don't have enough data to make a judgment one way or the other, but the expert consensus is that we should do it. And there was a grade N, we don't have enough data one way or the other, and the experts don't have an opinion. So the first recommendation, which got a grade A, was for patients who were over 60 years old. And this is where I think there was a change from the previous recommendations. For patients over 60, the threshold for treatment was 150/90, and the goal was 150/90. And if you got the blood pressure down that low or slightly below, you didn't have to keep going. There was no benefit to being more aggressive with therapy. So the first one was for patients 60 or older, 150/90. Recommendations 2 and 3 had to do with people under the age of 60. And there, it was the threshold and the goal was 140/90. So a little different depending on the age, having to do with the duration of being exposed to high blood pressure and the increased cardiac and cerebrovascular risks of that. Recommendation 2 and 3 were grade E, by the way. Recommendation 4 was for those with chronic kidney disease. The goal and the threshold and the goal was 140/90. Grade E. Recommendation 5 was for diabetics, and this is the other part where I think there was a departure from previous recommendations, and that was if they had diabetes, the threshold and the goal was now 140/90. Previous recommendations had been lower, they raised that up a bit. Recommendations 6 and 7 had to do with differing patient populations. If you were treating a non-African American population or patient, including diabetics, then your first-line drug should be either a thiazide, ACE, ARB, or a calcium channel blocker. And you should avoid using a beta blocker or an alpha blocker or a loop diuretic as your first-line therapy. They can be fine for third and fourth-line therapies, but not for your first-line therapy. That got a grade B. If you were treating an African American patient, then your first-line drug choice should be a thiazide or a calcium channel blocker. If that African American patient was diabetic, then you could consider using an ACE or an ARB as first-line therapy, but that got a grade C recommendation. The first one here was a grade B, but the diabetic using an ACE or an ARB was a weak recommendation. Recommendation 8 had to do with patients with chronic kidney disease and that their first-line drug choice should be an ACE or an ARB. That sort of makes sense. Recommendation 9 was sort of common sense in terms of titrating. Recheck in 4 to 6 weeks. Maximize your initial drug before moving on to a second drug choice. Avoid using both ACEs and ARBs in the same patient because there's very little benefit of that combination. And if you're not at goal by your third drug, then check for renal artery stenosis and refer to either cardiology or nephrology. This is just sort of the algorithm that they sort of pointed out, and I really do think that the major change had to do with the over 60-year-old patient population, raising it to 150/90 and not having to be more aggressive than that, and in the diabetic population where their threshold and goal rose to 140/90. And the only caveat about this is these recommendations were specifically for patients with just hypertension. And so all of you out in the trenches seeing patients of all sorts and their main problem is hypertension, these are great recommendations. For the cardiologists, we're seeing patients with heart failure and angina and coronary disease and all sorts of other comorbidities. It may alter or change some of our choices in terms of medications. So that was the hypertension recommendations. The cholesterol recommendations are a little bit more muddied and a little harder to understand. And the first thing to say is that not everybody agrees with the cholesterol recommendations as they've been formulated by this panel. And what I think that really means is it's not that the old recommendations were bad, it's not that the old way we were thinking is bad, and I think you end up taking a little bit of each and trying to come up with what you think is the best thing for the patients. So last December, the American College of Cardiology came out with new cholesterol guidelines. And some of the interesting things about this guideline set was they only considered randomized clinical trials in terms of the data that they looked at to make their formulations or their recommendations. And because of that, it's a very statin-centric type of recommendation algorithm. And most importantly, and the thing that I think is so discordant with our previous thinking and teaching is there's no longer this treat to a goal LDL. There's no longer, you got to get the LDL down below a certain mark. And it really has to do with the intensity of therapy, and that intensity of therapy is related to the efficacy of the drug therapy. And I'll show you that in a second. They divided patients up into 4 clinical groups. The first group was those with clinical atherosclerotic or cardiovascular disease. And that's defined as anybody with acute coronary syndrome, previous MI, stable angina, stroke, peripheral vascular disease, or abdominal aortic aneurysm. What it doesn't include, though, and a departure from the past, is patients who have imaging identified atherosclerotic disease. Subclinical disease, but they've got something on their carotid duplex scan. So that was not in their recommendations, though I tend to treat people the same way as this clinical group. The second group was for diabetics, but their age range was from 40 to 75. So they didn't say anything about diabetics over the age of 75 or younger than 40. After hearing Dr. Nakai's talk, I'm tending to think that particularly for the over 75 group, you just treat them as the same as the under 75 group. Then they broke it down into patients who have very high LDLs, 190 or greater. That's the familial hypercholesterolemia. Those are patients who have really difficult lipid issues. But probably the biggest group and the one that's got the most attention was this primary prevention group. And that's the group you see in your office, we sometimes see in our office, but it's really a big part of what you see in your practices. Probably the best thing from this recommendation was it now gave us a lower limit of when to start treating. These recommendations were for patients between the ages of 40 and 75. How many times have you asked yourself, gee, how, this is a 42-year-old, should I really be putting them on a drug at this young of an age? Well, this gave us some guidelines. And it mainly involved using an atherosclerotic cardiovascular disease risk calculator. There are references in the syllabus and here on the slides for web-based risk score calculators. They're all over the web. It's all the same thing. I've got one on my iPhone. I can show you. You get it. It's free from the App Store. It's not a big deal. It's going to be very helpful. So in terms of intensity of therapy, the way these guidelines shook out was that high-intensity therapy was defined as drug therapy which was likely to lower the LDL cholesterol more than 50%. And that was high-dose torvastatin or rosuvastatin therapy. I know I'm speaking out of turn when I say that's old term Lipitor and Crestor. Moderate intensity statin therapy was defined as lowering the LDL 30 to 50%. That's moderate dose of torvastatin or rosuvastatin, moderate to high dose simvastatin and pravastatin, and high dose lovastatin, fluvastatin, or pitavastatin. Pitavastatin is Livalo. And then low dose statin therapy, which I didn't really mention much, was the doses of these drugs. So it really has to do with the efficacy and dosing of the drug regimens. For the group with clinical atherosclerotic cardiovascular disease, this is what we in the past have termed secondary prevention. If they're less than 75 years old, they get high-intensity statin therapy that got a grade A. If they're older than 75, they get high-intensity statin therapy. Got a grade E though, but it's still the same thing. So if they've got disease, you treat them with high-intensity statin therapy. Again, not treating to a certain goal LDL, just the intensity of therapy. For the diabetics, again, between 40 and 75, this is where they said use that 10-year risk calculator and look at their risk. If it's less than 7.5%, then they should get moderate intensity therapy. If it's 7.5% or greater, high intensity therapy. So all diabetics get statin therapy if they're between 40 and 75. It's just what intensity therapy do they get. When it came to less than 40 or over 75, with the grade E, they said you're on your own. You can discuss the risks and benefits with the patient and make a decision about starting therapy. I think particularly for the over 75, group, I personally would just treat them like the under 75 group. The patients with the very high LDL cholesterols over 190, the obvious, check for secondary causes. Check their diet, look for anorexia, nephrotic syndrome, biliary obstruction. Drugs like cyclosporine, steroids, even amio can raise cholesterol a bit. Most importantly, though, high-intensity statin therapy. And what they're looking for was, again, not a goal LDL to get down to, but at least a 50% reduction in the patient's LDL cholesterol. And this was the one group where they said, you know, you might want to consider non-statin agents, such as a bile acid binding agent or ezetimibe. Niacin's a pretty weak LDL lower, and fibrates have no role in lowering LDL, so they wouldn't even be considered. But this was the one group where they said you might want to consider a non-statin drug. Again, the biggest group, the one that affects you guys the most, is the primary prevention group. So 40 to 75, LDL of 70 to 189, use this risk calculator. If their atherosclerotic risk is 7.5% or greater, they get high-intensity statin therapy. If it's between 5 and 7.5%, moderate intensity statin therapy with a grade of C. If it's less than 5%, they don't need therapy. Now, interestingly, these recommendations made no mention about what you should do for patients who are with heart failure or, and probably even more importantly, patients who are on dialysis, because that's a group that's at very high risk for vascular disease. So in summary, there appears to be little or no role for statin agents based on these recommendations. And again, there are no specific targets. This is a web-based version of that pooled risk calculator. You can find that, just Google pooled risk calculator. On the iPhone, it's called the 2013 Pooled Cohort Equation. It's available at the App Store for free. Don't buy it. It's free. And that's very handy because it takes you about 30 seconds to look at their cholesterol, their blood pressure, their race, whether they smoke, whether they have diabetes, and it will give you their 10-year risk for fatal or non-fatal heart attack, fatal or non-fatal stroke. And that you can share with the patient, and oftentimes that's very helpful in telling the patients or showing the patients why you're recommending this particular therapy or not. So the hypertension guidelines are much easier to understand. These are a little foggier. I hope I've helped and not made it more confusing, as Tom Bertoli pointed out when he was talking about diabetes, making it more confusing. Thank you very much, and I really appreciate your time and attention. Any questions? Jim? Wait, I'm sorry, I can't hear you.
So you say not to use a target number, but the percentage reduction is itself creating a target percentage. So if you know their pre-treatment LDL and you're trying to lower it by 50% or more, then you know your post-treatment target.
Yes, you're saying if I use math, I can figure out what their target number is.
I mean, they might be a diabetic with an LDL of 120, but that means their LDL would have to go down to at least 60.
Yes. Well, again, what you're pointing out is, well, what happens, it's the kind of thing where, well, I've got the patient on moderate intensity therapy, but their LDL is 49. Did I really get a 50% reduction, or should I go to something higher but get their LDL number down even lower? That's where these guidelines are kind of very foggy. Andy? In hypertension? The reason I kind of thought the same question, and what the guidelines say is that there are a couple of studies which have shown increased cerebrovascular events in patients treated first line with beta blockers and alpha blockers, and that's why they did not include them in their recommendation for first line drugs, because of a couple of studies which suggested an increased risk of stroke, not of MI, but of stroke. That was the reasoning. Yes?
Could you comment on the JNC8 recommendation for screening for renal artery stenosis in resistant hypertension in light of the CORAL trial that basically showed that medical therapy is probably just as good as stenting?
Thanks, Tom. What the gentleman is pointing out is, why would you screen for renal artery stenosis if indeed some of the recent trials have suggested no clear benefit from renal intervention? I think the CORAL trial looked at one very specific subset of patients with renal artery stenosis, and it may be that there are some patients who might benefit from renal artery intervention. It's also important to know that that's what they have, just as part of their whole atherosclerotic picture. Yes, Jason.
If you plug the same numbers into the new ACC-AHA risk calculator and the Framingham risk calculator, you get very different assessments of risk many times. Could you comment on that, please?
Yeah, what Jason is pointing out is that there's a discrepancy, or there appears to be discrepancies between various risk calculators. The same thing can be said when you plug in somebody who would be greater than 75%. With the European guidelines, they come out being much lower. I don't have a good explanation of why that is. That's one of the criticisms and controversies that's ongoing. That's why not everybody buys into these guidelines. I mean, your point is very valid. Jim?
I want to ask a question about the aortic valve prostheses. Are there any that don't use tissue in trials or in development? I'm thinking of my patients who calcify the tissue valves.
The answer is no. They all are tissue valves, so they can be folded down very easily. Now, having said that, one of the things that I didn't talk about is that there's a move to use more tissue valves as the primary valve, because that allows the patients to then have a second valve, transcatheter valve, down the road. And the same would be true in your patients who might heavily calcify a bovine or a porcine pericardial prosthesis fairly early, but they can still get a second, they call it a valve-in-valve, where we can do a second TAVR procedure inside the first TAVR procedure. So that doesn't exclude it. The problem is the mechanical valve just cannot be compressed into a small enough conformation to get it across the valve.
So my question is, practically speaking, are you addressing these changes with your patients as they come into your office, in terms of, are you changing them to the high-intensity statins in your office? How are you implementing these changes?
Personally, I put everybody, or when most patients come into my office, they've got atherosclerotic disease. So by definition, they're going to need high-intensity therapy. I think the harder question, sort of what you're getting at, was, well, do you just put them on a drug, or do you check the LDL to see if you've gotten down to where you kind of were where you used to think? If you'd asked me back in December of 2013, I would have said, yeah, we got to get their LDL down between 50 and 70 milligrams per deciliter. And that's the hard part I have. I'm used to thinking about that goal LDL target, and that's why these recommendations are so difficult to sort of reconcile with what we do on a regular basis. My personal practice is to get everybody on a high-intensity therapy when they have atherosclerotic disease.
Thank you.
Thank you very much.
Thank you.